like to tell you about our speaker, Dr. Brown. He's a board-certified urogynecologist and the director of women's health with Urology Associates. Dr. Brown grew up locally and attended Millsaps College, where he graduated with honors and played collegiate football. He completed his medical degree at the University of Alabama School of Medicine and his residency at the University of Mississippi in Jackson. Continuing education is extremely important to Dr. Brown, and as such, he offers the latest urogynecology procedures. His training, combined with his extensive experience, allows him to offer advanced care in non-surgical methods, minimally invasive surgery, and complex surgical cases. He's proficient in laparoscopic, robotic, and neuromodulation procedures and serves as an educator to other physicians. So tonight, Dr. Brown will share information about his experience in treating patients with bladder and bowel issues. He'll review some of the most common symptoms that patients experience and treatment options to help you find real relief. So without further ado, I'd like to welcome Dr. Brown.
Thanks everyone for joining us tonight, and I really appreciate Stacy helping me with this webinar as well. I'm really excited to have the opportunity to talk with you about some distressing bladder and bowel conditions, things like overactive bladder, urinary retention, bowel incontinence, and stress urinary incontinence. These are super common conditions, but they're often under-discussed, and patients may not discuss them because of embarrassment. And I really love what I do, and I love that there have been so many advances in urogynecology, and there's so many more things we can do for patients. And so I'm excited to give you this talk. So my goal today is to get the point across that if you or someone you know are experiencing these conditions, it's not something that you have to live with. If you leave today saying, I have options and I don't have to live with this, then I've done my job. You don't have to get into all of the detailed slides about different problems. That's something that we can do when you come to see us in the office. Basically, like I said, if you have these issues, there are options for you, and you need to see a physician or other provider that treats these conditions regularly. Let's start with the big picture. These symptoms can be incredibly disruptive to your life. They don't just affect one part of someone's life, they impact daily routines, confidence, social interactions, even work and relationships. And one thing that I want to emphasize is that these conditions are not just a normal part of aging. It's not something that you have caused. Just because these things are common doesn't mean that it's something you have to live with. There are medical conditions that have real effective treatment options. The running theme is that you have good options and don't live with it. When you look at all the things that these conditions can impact in life, they go way beyond physical symptoms. Patients may avoid activities, they may travel less, they may feel anxious or even withdraw socially because they're nervous about having an accident. Patients may not go to the grocery store or to church. They may forego traveling to visit their family. They may not see their grandchildren, or because they don't want to have an accident on the way. So treating conditions like these is really about restoring your quality of life, just not just managing symptoms. I think about my grandmother growing up. She had problems with incontinence, and she didn't really have good options back then. And you or whoever has experienced these conditions, we do have good options now. She also wasn't healthy enough to have anything done. So now we have more minimally invasive options. So what specifically are we talking about? So first is overactive bladder, which is urgency and frequency. So you go to the bathroom, you urinate frequently, or you leak on the way to the bathroom. Just the opposite can be urinary retention, where you're not completely emptying. And bowel incontinence or fecal incontinence is the loss of bowel control or soiling your underwear. These are all different conditions, but they can be all treated with similar underlying issues. And that's why there's similar underlying issues. So that's why we group them together. There are actually two different types of urinary incontinence, just to let you know that we see most commonly. Overactive bladder is when you can't make it there fast enough or have an urge to go. The other one is stress incontinence, which is treated totally differently. Stress incontinence is when you leak, when you cough or sneeze or jump or put pressure on your bladder and can't hold your urine because your urethra or the tube that comes out of the bladder is not strong enough to hold it back. Stress incontinence is something we're going to talk about separately at the end of this talk, but I just wanted you to know there's two different types of stress or types of urinary incontinence. They're treated differently. So if you had a friend that was treated for one or the other and they say, oh, that didn't work, sometimes it's because they had what's called mixed incontinence, where they had both. So if they have both stress and urge, we may do something to fix one and not the other, and they think that they weren't cured, but we can cure both of those, or at least improve both of those. So back to those that we're lumping together: the overactive bladder, the urinary urgency, all of these things. Overactive bladder, patients may feel a sudden, hard to control urge to go. They may be going frequently, waking up at night, or experiencing leakage. It's really frustrating and embarrassing for patients to have this loss of control. About 50 to 60% of adult females and about 75% of women over age 65 experience some form of urinary incontinence, so you're not alone. Another issue could be the opposite of leaking. So this would be urinary retention. That's about not being able to empty your bladder. Patients may feel like they constantly need to go, but they can't fully empty. So they make frequent trips to the bathroom with very little coming out, which can be just as disruptive. At a basic level, the bladder has two jobs: to store urine and to empty on command. It relies on coordination between muscles and nerves. So when that communication breaks down, that's when symptoms start showing up. There's the same idea with bowel incontinence or bowel function. Bowel incontinence can show up as urgency, leakage, or losing stool without awareness. And again, this can be extremely difficult for patients, probably more difficult than urinary incontinence, because patients are much more likely to bring up urinary incontinence. Fecal incontinence is something people are very, very reluctant to tell their physician or to tell anyone. It's probably more common than we even know, because patients are, like I said, reluctant to tell us because of embarrassment. Up to 25% of the female population will have bowel incontinence sometime in their life, but it's probably much higher. And bowel incontinence is, not necessarily when they have a bout of diarrhea. I think people that happens to lots of people. I'm talking about people that have it regularly, once or twice a week, or even more frequently than that. Bowel function is complicated. It involves your muscles, your nerves, and messages from your brain. So when the message is off, bowel control is compromised. The good news is there are treatment options, and patients don't realize how many options exist beyond just you have to live with it. So if your physician's telling you have to live with it, or you just have decided you have to live with it, you're wrong in most cases. So typically patients start with discussions with their physician. They discuss their symptoms, They may track their symptoms with diaries. They may go through some other testing. If the initial treatments don't work, that's when we look at more advanced options. And the key message again here is don't give up at the first step. If the first step doesn't work, there are many other options. So if you're going down the pathway, you have to start from the least to the most, but there are incredible advanced options. And since I've been in practice the last 30 years, things have gotten better and better and better and better, and we have pretty incredible options. So there's really a spectrum of treatment from behavioral and lifestyle changes all the way to advanced therapies. This applies to overactive bladder, urinary retention, and bowel issues. Early on, we start simple, like bladder training, diet changes, medications. If that doesn't work, then we move to more advanced therapies. We can use Botox, like you use Botox to remove wrinkles. The way that Botox works to remove wrinkles is that it makes the muscles in your face relax a little bit, and so your wrinkles go away. With Botox for the bladder, it can relax the bladder muscle so that it doesn't contract and cause you to leak when you don't want it to. Another advanced therapy is called sacral neuromodulation, which we'll discuss later in this talk. Urinary retention can be sometimes a harder thing to treat. For women, there's not necessarily a medicine that can make a difference. Pelvic floor physical therapists can help to retrain the way that you urinate so that you urinate correctly. Most of us don't urinate correctly. I don't think people realize most of us try to push to urinate or strain. And so you have a muscle in your bladder that's not really under your control. So that bladder muscle empties itself. The way that it knows to empty itself is that you relax your bottom, you relax your urethra, the tube that comes out of the bladder, and your bladder empties because the muscle says the gate's open, it empties itself. But most of us try to push, and when we push, we make that urethra smaller and smaller and smaller, and it stops. So having a physical therapist teach you to urinate correctly can be helpful. Medications help in relaxing the urethra to allow the urine to pass. Prostate issues can cause some trouble with urinary retention, and it's treated by my partners mainly. Personally, I'm a urogynecologist, and I specifically treat women, but I do have partners that may be able to help you and your male friends or relatives. For urinary retention, the more advanced therapies would be catheterizing yourself intermittently to empty your bladder, or in extreme cases, some patients have to have a permanent tube placed. Because that seems very extreme to me and is not what I would want. That's the main reason we're talking about this, is because we may have an easier option with sacral neuromodulation that could help with this problem. With bowel incontinence, you would start with your gastroenterologist, making sure that you don't have a digestive issue like lactose intolerance or something dietary that you're eating, making sure that you're up to date with your colonoscopy and that it's not some sort of colon cancer that's causing your issue. And again, pelvic floor physical therapist can help you to have a bowel movement more physical, like you have a bowel movement the way that you're supposed to. So over-the-counter medications like Imodium can be really helpful for bowel incontinence. Sometimes the problem can be opposite of diarrhea. That constipation can cause the urge to have a bowel movement, and it can cause seepage around the blockage. So your body's trying to get rid of that constipation, and you may have diarrhea around it. If this doesn't work, then advanced options are an option. So in the past, surgical advanced therapies for bowel incontinence, mainly that we repaired the sphincter muscle or the muscle keeping your bowel movement in. These are many times not effective long-term, and they're very uncomfortable, and it's a very difficult recovery. So that's why I'm really excited about sacral neuromodulation as an option for bowel incontinence. And it actually has become the standard therapy over these other surgical interventions for the treatment of bowel incontinence. So, like I said, one of the important advanced therapies is sacral neuromodulation. It's a big word that we'll talk about. We all have nerves that send signals to our bladder and our bowels. If those nerves are sending the wrong signals because of aging or some sort of neurologic diseases like multiple sclerosis, or you have back or lumbar issues or spinal stenosis, all those things may cause some of these issues. They may cause overactive bladder, urinary retention, and bowel incontinence. So if we block those abnormal messages that are going to your bowel or your bladder and allow the normal messages to get through, we may be able to improve your symptoms. And how do we do that? So if you think of this as a communication problem, sacral neuromodulation, like I said, is a big fancy word for improving the communication between your brain and your bowel or your bladder. And we see incredible outcomes in terms of symptom improvement with sacral neuromodulation. So what's nice about sacral neuromodulation is that it starts with a simple test in the office or in the outpatient surgery center. So you come into the office under local anesthesia. We place two little hair-thin wires down by your buttock, and they're literally hair-thin. They're like the size of a very thin guitar string. You go home and for a trial for 3 days. And if you show at least a 50% improvement in your symptoms, so if you're going through 12 pads a day or 3 pads a day and you go down to half that number, then that's a successful trial. Many patients get a higher improvement than 50%, but you need at least a 50% improvement. So patients can have a test. They can test it out and see if it works for them. And if it doesn't, they haven't lost anything. They can take a test drive, and when it helps them, most of them beg to have the full treatment. Lots don't want to have the wires removed because it's working so well, but we remove the wires, and then we can, in a short period of time, then schedule a time to place the actual device that may help you for long term. Sacral neuromodulation has been around for the last 30 years. I've been using it in my practice since around 2005, but the recent advances have made it really a much better option for many more patients. For years, there was only one company that had a device for sacral neuromodulation. That company didn't have the incentive to innovate, but fortunately, in 2019, Axonics devices came to the market, and with the competition, there have been exponential advances in the therapy. Axonics has 2 options for implants for sacral neuromodulation. They have a small rechargeable option. It's about the same size as an Apple Watch or an Andes Mint packet, and the other one is only slightly larger, and it's recharge-free system. Both of them, we get routinely 10 to 20 years of improvement, and so it lasts for 10 to 20 years. The rechargeable may last even longer than that. It's MRI compatible, so even the largest MRI systems, this can be used for that. So in the past, with the other devices that we had, they only lasted for about 3 to 5 years, and so you had to replace them. And then if a patient had to have an MRI, you had to take it out. Now that's not an issue. So patients can have an MRI with this, and it lasts for 10 to 20 years. In my practice, we did a study, and the average was about 18.5 years that it lasts. So lasting 18.5 years. And if it works 18 years, then we just change out the battery. And it has a 90% long-term satisfaction. So incredible improvement in patients. Not necessarily completely, we do have patients that have complete improvement, but it's kind of a team effort. So we have to do behavioral and other things as well. But 90% long-term satisfaction for a minimally invasive procedure. So shifting gears to stress urinary incontinence. So different than overactive bladder, stress urinary incontinence is related to physical pressure, like coughing or sneezing or exercising causing leakage. So jumping on a trampoline with your grandchildren or your children, or, I have patients that are even younger that have issues with stress incontinence and overactive bladder. Stress urinary incontinence, or SUI, is very common, especially in women. Roughly half of adult women will have stress urinary incontinence during their lifetime. Lots of that is because of childbirth, but we have patients that have never had children that have stress incontinence. You can see here that stress urinary incontinence is related to a weak urethra. So the urethra is, if you think of the bladder as kind of like a balloon, the little stem of the balloon is called the urethra, and that stem can be weak. And so your bladder just leaks out, especially if you have any pressure that places on your bladder, it causes it to leak. So if you cough or sneeze or increase your abdominal pressure that presses on your bladder, then your urethra relaxes and leaks. So what are the treatment options for stress urinary incontinence? You can start with Kegel exercises, tensing those muscles that start and stop your urine stream. You can start with lifestyle and pelvic floor exercises. Kegels have about a 60% improvement rate, but the drawback is that you have to do them every day or your symptoms will return. So you have to tense those muscles 10 sets of 10, 100 times a day for the rest of your life. And there's some patients that'll do that. I do not have many in my practice that will do that. And so, and as the options have improved over time, many of them choose to do something else. So options for stress incontinence are like vaginal inserts, like pessaries. You can, over the counter, there's a device called Impressa that puts pressure on the urethra. It's kind of like a tampon, the bladder opening to keep it closed when you cough or sneeze. That works for some patients, not many in my practice. Obviously, I see a lot of patients that continue to have issues, but sometimes they can work. I haven't seen great success with these. They can be effective in some patients. Before the 1990s, our surgeries for stress incontinence were much more involved. They had a much longer recovery with much more discomfort. They had 6 weeks recovery. Now we have much better options with shorter, easier recovery and nearly pain-free, very little discomfort. So tension-free mid-urethral slings have been out since the 1990s. They're the gold standard for treatment of stress incontinence. So fortunately, that was about the time, the late 1990s was when I started. I did the older procedures, and tension-free mid-urethral slings were revolutionary. So under anesthesia for about 20 minutes, we make a little small incision and place a little thin tape on your urethra, and it presses on that urethra so that when you cough or sneeze, the urethra is able to close. 90% of patients that have slings are dry or improved with the urinary incontinence, with long-term success rates out to 15 years and probably forever. So it's a quick outpatient surgery with a quick recovery and 90% success rate. I have a nurse practitioner Jennifer, who's incredible, and my wife as well. Both have had this and don't leak anymore. My wife says it's life-changing. So the other option that we offer is urethral bulking. Urethral bulking has been around for years, using materials like collagen. So if you think about collagen for your lips, they inject collagen in your lips. You can inject collagen around the urethra while you're asleep, or you can do it in the office, but usually while you're asleep. This makes the urethra smaller so that when you cough or sneeze, it closes. The problem with collagen is that it absorbs, so it goes away. So there's improvement, but those injections only lasted about 6 months to 3 years. In the last, about the same time as Axonics came out, Bulkamid came out, which has been a game changer for patients. It makes small water pillows in the urethra that aren't absorbed, and they help with preventing you from leaking when you cough or sneeze. Just making that urethra a little bit smaller so that weaker urethra is able to close. Because the water pillows aren't absorbed, Bulkamid has a 73% completely dry rate and a 93% dry or improved rate out for 7 or more years. So the TVT has a 90% completely dry rate and a 97% dry improved rate. This has a little bit lower, but has very good success and probably last for a long time, if not forever. I'll pause there, and I'm happy to answer any questions. You just for you to know, I have a nurse practitioner